Evaluation and Management of Hypertensive Emergencies. Kimberly Zammit, Pharm.D, BCPS, FASHP. Clinical Coordinator, Buffalo General Hospital. Zammit@colliderhealth.org. Learning objectives define the J&C7 classification of blood pressure. Differentiate the presentation and management strategies for hypertensive urgencies and emergencies. Compare and contrast pharmacotherapeutic agents available for the management for acute blood pressure control. Identify treatment goals for patients requiring acute blood pressure management. Recommend antihypertensive therapeutic regimens tailored for specific patient characteristics. Epidemiology. American Heart Association estimates 73 million Americans have high blood pressure. 1 to 2% of hypertensive patients will have a hypertensive emergency in their lifetime. Represents 3% of all ED visits and 25% of all medical urgencies/emergencies in the ED. 113 million ED visits in 2003. American Heart Association. Heart Disease and Stroke Statistics 2008. Zampalion B. et al. Hypertension 1996 27 to 144 to 147. Epidemiology. 51 YoWM is admitted to your emergency department with a CC of 2-day history of dull headache and blurry vision. He decided to come to ED today because he developed SOB and dizziness while exercising. PMH. HTN and hyperlipidemia. Vital signs. HR 105 BP 240/138 RR 24, T 37.6. Height 70, weight 95 kilograms. Pertinent physical findings reveal papilledema and a grade 2/4 SEM. Laboratory results. Now 135, K 3.5. CL 108, CO2 22, BUN 50, S 2.4. Troponin negative, thus far. Diagnostics. CXR, enlarged heart. CT head, no bleeding is evident. ACG, no ischemic changes, evidence of LVH. Medications. Metoprolol 100 mg bid, stopped 1 week ago. HCTZ 25 mg daily. Simvastatin 20 mg daily. Aspirin 81 mg daily. Social. Former smoker, social eto, denies illicit drugs. Allergies. NKDA. This patient is classified as having a hypertensive emergency because he has a blood pressure of greater than 180, 110. True. False. Hypertension nomenclature, J&C7. Category. SBP, Hg. DBP, Hg. Normal. Less than 120. Less than 80. Prehypertensive. 120 to 139. 80 to 89. Hypertension. 140 to 179. 90 to 109. Hypertensive crisis. Greater than or equal to 180. Greater than or equal to 110. JNC8 will be released late 2009/early 2010. SBP greater than 240 mm of mercury or DBP greater than 140 mm of mercury, usually for hypertensive emergencies, Mansour et al. Hypertensive emergency is not defined by any absolute blood pressure. Measurement. Hypertensive emergency, malignant hypertension, accelerated hypertension. Hypertensive crisis. Hypertensive urgency. Hypertensive emergency. Elevated BP without evidence of acute end organ damage. Elevated BP with evidence of acute end organ damage. Malignant hypertension. Accelerated hypertension. Retinal hemorrhages, exudates, and papilledema. Renal involvement in the form of malignant nephrosclerosis. usually associated with a DBP greater than 130 mm Hg. Similar to malignant hypertension, but papilledema is absent. Better prognosis than malignant hypertension. The 1993 report of the Joint National Committee on Detection, Evaluation, and Treatment of High Blood Pressure 1 proposed an operational classification of hypertensive crises as either emergencies or urgencies. Severe elevations in blood pressure were classified as hypertensive emergencies in the presence of acute or ongoing end organ damage, or as hypertensive urgencies in the absence of target organ involvement, a certain degree of which can pose an immediate threat to the integrity of the cardiovascular system. Distinguishing hypertensive urgencies from emergencies is important in formulating a therapeutic plan. In the former, the goal is to reduce blood pressure within 24 hours, whereas in the latter it is to lower blood pressure immediately, not necessarily to normal ranges, to prevent or limit target organ disease. 123. Etiology: essential hypertension, renal disease, endocrine disease, parenchymal disease, renal artery stenosis, renal crisis from systemic sclerosis, systemic lupus, post-renal transplant, tubulointerstitial nephritis, endocrine disease, pheochromocytoma, glucocorticoid excess, primary aldosteronism, renin-secreting tumor, cerebrovascular disease, ischemic stroke, intracranial hemorrhage, head injury/SNES trauma. Vidu et al., Hospital Physician, March 2007. Kabanian A. et al., Hypertension 2003 /42-6, 1206-1252. Etiology: other medications, eclampsia/severe preeclampsia, burns, vasculitis, autonomic hyperactivity, pregnancy, sleep apnea. Medications: non-compliance, illicit drug use, drug interactions, adverse effect. Vidu et al., Hospital Physician, March 2007. Kabanian A. et al., Hypertension 2003 /42-6, 1206-1252. Organs at risk: neurovascular, ocular, cardiopulmonary, renal, subarachnoid hemorrhage, intracranial hemorrhage, cerebral infarction, hypertensive encephalopathy, ocular, papilledema, retinopathy, cardiopulmonary, decompensated HF, pulmonary edema, aortic dissection, ACS, LV dysfunction, renal failure, proteinuria, pathophysiology of end organ damage, abrupt increase in SVR, mediated by humoral vasoconstrictors, Ra activation, mechanical stress, endothelial injury, pressure natriuresis, vasoconstriction, cytokine activation, increased permeability, activation of coagulation and platelets, deposition of fibrin, renal vasoconstriction, endothelial injury, arterial necrosis, end organ hypoperfusion, ischemia and dysfunction, ischemia and release of vasoactive mediators. Marek P., Varon JHS 2007 131-1949-62. End organ damage, hypertensive emergency. Frequency, %. Cardiovascular 55.3. Acute pulmonary edema 22.5. Acute congestive heart failure 14.3. Acute coronary syndrome 12. Eclampsia 4.5. Aortic dissection 2.0. SNES complications 45.3. Cerebral infarction 24.5. Hypertensive encephalopathy 16.3. Intracerebral or subarachnoid hemorrhage. Mean blood pressure 210/130 of a millimeter of mercury. No patients with emergency had a DBP less than 120 mm of mercury. Total number patients equals 108. The aim of the present study was to evaluate the prevalence of hypertensive emergencies and urgencies in an emergency department during 12 months of observation and the frequency of end organ damage with the related clinical picture during the first 24 hours after presentation of the patient. Zampalione B. et al. Hypertension 1996 27 to 144 to 147. Signs and symptoms 2217 27 10 21 headache 3 epistaxis chest pain 9. Signs and symptoms: HTN urgency, %. HTN emergency, %. Headache 22. 3. Epistaxis 17. Chest pain 9. 27. Dyspnea, faintness 10. Agitation 2. End deficit 21. Vertigo 7. Paresthesia 6. 8. Vomiting, arrhythmia. Zampalione B. et al. Hypertension 1996 27 to 144 to 147. Short term, 2 to 6 month, outcomes. Acute condition death re-hospitalization ACS 1,2,35 to 7% 30% 4 Swiss francs 8.5% 26% severe hypertension 5 11% 37%. Oasis 5 Nejm 2006. Gusto IIB Nejm 1996. Grace Jammer 2007. Impact HFJ Cardiac Failure 2004. Stat Registry Results. Initial Evaluation Early Triage Medications Patient History PMH. Obtain BP at least twice. Medications. Current meds OTCs. Compliance. Drug interactions. Recreational drugs. Cocaine. Amphetamines. Phencyclidine. Patient history. PMH. Family history. Baseline BP recordings. Recent activities. Symptoms. CV. Renal. Neurologic. Amphetamines, cocaine, phencyclidine. Physical exam and diagnostics. Focus on detection of end organ damage. Physical examination. Neural exam. Focal findings. Mental status changes. Fundoscopic exam. Cotton wool exudates. Hemorrhages. Papilledema. Cardiac exam. Heart sounds. Pulses. Diagnostic studies. Urinalysis. Electrolytes. BUN and SCR. CBC/platelets. Chest X-ray. EKG. Serum glucose. Brain CT MRI. Hypertensive emergency initial treatment goals. Prompt, but controlled reduction in BP. Reduce MAP by less than 25% during the first minute to 1 hour. If stable, reduce to 160/110th of a millimeter of mercury within the next 2 to 6 hours. Gradual reduction to goal over next 24 to 48 hours. Exceptions: ischemic stroke, stroke eligible for TPA, acute aortic dissection, SAR, ICAH. Choice of agent should be tailored to clinical situation. Type of end organ damage, presentation. Kabanian A, et al. Hypertension 2003 1206 to 1252. Hypertensive emergency initial treatment goal exceptions. Ischemic stroke, noted per candidate. Treat SBP greater than 220 mm of mercury and or DBP greater than 120 mm of mercury only. Ischemic stroke. Per candidate. Treat SBP greater than 185 mm of mercury and or DBP greater than 110 mm of mercury. Acute aortic dissection. Rapid reduction, 5 to 10 minutes, to SBP between 100 to 120 mm of mercury, if tolerated. Subarachnoid or intracranial hemorrhage. Balance risk of rebleeding with risk of reducing cerebral perfusion pressure. Mean arterial pressure (Hg). Cerebral autoregulation. 100. Normal regulatory range. Cerebral blood flow, ml per minute/100 grams. Normotensive. 50. Chronically hypertensive. MAP equals 1/3 SBP DBP plus DBP. 50. 100. 150. 200. Mean arterial pressure (Hg). Death or dependency at 6 months. Blood pressure versus outcomes in acute ischemic stroke. Death or dependency at 6 months. Mortality 14 days. Leonardo B. Stroke 2002 33, 1351 to 1357. The ED resident would like a recommendation for the best antihypertensive in this patient. Labetalol, esmolol, phenyldopam, nitroglycerin, parenteral antihypertensives. Beta blockers. Labetalol, esmolol, metoprolol. Calcium channel blockers. Nicardipine, clevidipine, verapamil, diltiazem. Vasodilators. Nitroprusside, nitroglycerin, hydralazine. Miscellaneous. Enalaprilat, phenyldopam. First 4 antihypertensive agent. www.outcome.org/stat. Number of antihypertensives required to gain BP control. www.outcomes.org/stat. Hypertensive emergency treatment disease-specific recommendations. Conditions. Preferred agent. Goal. Risks. Preeclampsia, eclampsia. Labetalol. Nicardipine, hydralazine, magnesium sulfate, seizures. 160, 110, 150, 100 if platelets are less than 100 K. Hypotension. Acute renal failure, microangiopathic anemia. Nicardipine, labetalol, nitroglycerin. Reduce BP 20%. Hypotension and worsening renal failure. Cocaine intoxication. Beta blockers are contraindicated, even labetalol. Labetalol does not reverse coronary artery vasoconstriction. Hypertensive emergency treatment. Disease-specific recommendations. Conditions. Preferred agent. Goal. Risks. Sympathetic crisis. Cocaine or other sympathomimetic. Pheochromocytoma. MAOIS/tyramine. Abrupt clonidine or beta blocker DC. Phenyldopam, nicardipine, verapamil or diltiazem in combination with benzodiazepine. Phentylamine. No beta blocker. Reduce excessive sympathetic tone. Relieve symptoms. Alpha storm. Acute postoperative hypertension. Esmolol, nicardipine, or labetalol. Cardiac surgery 140-90. Otherwise no specific goals. Excess reduction. Cocaine intoxication. Beta blockers are contraindicated, even labetalol. Labetalol does not reverse coronary artery vasoconstriction. Hypertensive emergency treatment. Disease-specific recommendations. Conditions. Preferred agent. Goal. Risks. Acute ischemic stroke. Nicardipine, labetalol. Treat when the greater than 220/120 except with thrombolytics greater than 185/110. Excessive BP decrease may worsen ischemia. Intracranial hemorrhage. Nicardipine, labetalol, esmolol. Treat to target MAP 130. Precipitous BP fall may increase mortality. SAR. SBP less than 160. Keep SBP greater than 120 to maintain CPP. Hypertensive encephalopathy. Decrease MAP 15 to 20%. Aggressive BP fall may produce ischemia. Hypertensive emergency treatment. Disease-specific recommendations. Conditions. Preferred agents. Goal. Risks. Acute myocardial ischemia. Labetalol, esmolol and NTG. Reduce SBP 20 to 30%. Beta blockade could worsen LV function. Acute aortic dissection. Labetalol, nicardipine and esmolol nitroprusside with esmolol. Reduce shear forces SBP 120 to 140 HR60. Need continuous BP monitoring. Acute pulmonary edema or heart failure. Nicardipine or nitroprusside with NTG and loop diuretic, may cautiously use enalaprilat. Reduce BP by vasodilatation, promote diuresis symptom relief. Worsening renal failure. What is the patient's immediate BP reduction goal? Decrease MAP 25 to 30%. Decrease MAP 15-20%. SBP no lower than 185. SBP no lower than 160. Labetalol alpha 1 and beta blocking properties, ratio 1 to 7. Onset, 3 to 5 minutes, peak 5 to 15 minutes. Duration, 3 to 6 hours. Safe in pregnancy. AE, bradycardia, bronchospasms, hepatotoxicity. Dosing strategies, 4, max 300 mg/day. 20 mg for bolus, repeat 20 to 80 mg increments Q10 min. Infusion, 1 to 2 mg per minute initial, titrate to effect. Caution, accumulation will occur. Rapid ability to reduce BP, due to alpha effects. HR maintained or slightly reduced, CO maintained. Hepatic metabolism, hepatic toxicity. Caution with HF, bronchospasms, severe asthma COPD, heart block. Infusion, may need to start with 4 bolus. OK in pregnancy. Esmolol ultra short-acting cardioselective beta blocker. Metabolism, RBC esterases. Onset, within 60 seconds. Duration, 10 to 20 minutes. Elimination half-life, 9 minutes. Dose, max, 300 micrograms/kg per minute. 0.5 to 1 mg/kg bolus over 1 minute, infusion at 50 micrograms/kg per minute, can increase every 5 minutes. Intermediate, peak 5 to 15 minutes. Esmolol. Labetalol. Administration. Bolus plus. Continuous infusion. Bolus. Onset. Rapid, 60 seconds. Intermediate, peak 5 to 15 minutes. Offset, duration of action. Rapid, 10 to 20 minutes. Slower, 2 to 4 hours. Heart rate. Decreased. +/ SVR. Cardiac output. Myocardial O2 balance. Positive. Contraindications. Sinus bradycardia. Heart block greater than 1 degree. Overt heart failure. Cardiogenic shock. Cocaine intoxication. Severe bradycardia. The onset of action for esmolol is 60 seconds and the duration of action is 10 to 20 minutes. For labetalol, the onset of action begins within 2 to 5 minutes after a loading dose, but the peak effect requires up to 15 minutes. Several bolus doses of labetalol over a period of 1 hour may be required to achieve target BP. Once treatment is stopped, labetalol effects will last 2 to 4 hours. Esmolol and labetalol differ in their effects on HR, SVR, and CO. In patients treated with esmolol, HR decreases, CO decreases with no change in SVR. Labetalol treatment may increase HR and CO slightly while decreasing SVR. Both agents result in positive effects on myocardial oxygen balance. 1. Varon J., Malik P. Chest. 2000 118 to 214 to 227. 2. Hoffman B.B. In, Hardman J.G., Limburgler, eds. Goodman and Gilman's Pharmacological Basis of Therapeutics. 10th ed. New York, New York, McGraw-Hill, 1997 to 215 to 268. Phenol-dopam peripheral dopamine 1 agonist. Improves creatinine clearance, urine flow rates, and sodium excretion in severely hypertensive patients with both normal and impaired renal function. Rapid, extensive hepatic conjugation. The onset of action is within 5 minutes, with the maximal response being achieved by 15 minutes. Duration of action is 30 to 60 minutes. An initial starting dose of 0.1 micrograms/kg per minute. Increase 0.05 to 0.1 micrograms/kg per minute to max of 1.6 micrograms/kg per minute. Nausea, headache, flushing. Pressure gradually returning to pre-treatment values without rebound once the infusion is stopped. Nitroglycerin potent vasodilator, higher doses affect arterial tone. Onset, 2 to 5 minutes. Duration, 5 to 10 minutes. Tolerance with prolonged infusions, greater than 24 hours. Second agent often required. Primary role in AMI, pulmonary edema. Vomiting, methemoglobinemia. ICP may increase, CO may decrease in volume depleted. Red blood cells contain 4 hemoglobin chains. Each hemoglobin molecule is composed of 4 polypeptide chains associated with 4 hem groups. The hem group contains an iron molecule in the reduced or ferrous form, Fe2+. In this form, iron can combine with oxygen, by sharing an electron, to form oxyhemoglobin. When oxyhemoglobin releases oxygen to the tissues, the iron molecule is restored to its original ferrous state. Hemoglobin can accept and transport oxygen only when the iron atom is in its ferrous form. When hemoglobin loses an electron and becomes oxidized, it is converted to the ferric state, Fe3+, or methemoglobin. Methemoglobin lacks the electron that is needed to form a bond with oxygen and, thus, is incapable of oxygen transport. Because red blood cells are continuously exposed to various oxidant stresses, blood normally contains approximately 1% methemoglobin levels. Sodium nitroprusside potent arterial and venous vasodilator. Onset, seconds. Duration, 2 to 5 minutes. Reduces preload and afterload. Arterial line required to monitor BP. Due to potency, rapidity of action, and tachyphylaxis. Disadvantages. Cyanide toxicity, increased ICP, coronary steal. May increase mortality after AMI. CN. Sodium nitroprusside cyanide toxicity protect from light dosing. Metabolized in liver to thiocyanate via thiosulfate. Thiocyanate eliminated via kidney. Both cyanide and thiocyanate cause toxicity. Add 1 gram sodium thiosulfate per 100 mg SNP to 4 bag to reduce toxicity. Protect from light. Dosing. Start 0.3 micrograms/kg per minute. Titrate every 5 minutes. Doses less than 2 micrograms/kg per minute. Low risk of cyanide toxicity in healthy patients. Max 10 micrograms/kg per minute. Short durations only due to risk of toxicity. Nicardipine. Dihydropyridine CCB, exhibiting selective vasodilatation. Onset, 5 to 15 minutes. Duration, 2 to 6 hours. Strong cerebral and coronary vasodilatory activity. Reduces BP but increases cerebral perfusion pressure. Dose. Initiate at 5 mg per hour. Titrate by 2.5 mg per hour increments. Rapid control titrate every 5 minutes. When desired result, reduce dose to 3 mg per hour. Gradual control titrate every 15 minutes. Max 15 mg per hour. Recommendation comes from post-operative hypertension patients. Experience suggests it often fails. To optimize blood pressure management in populations other than post-op hypertension. Safety profiles of nicardipine and nitroprusside. Adverse events. Nicardipine, nitroprusside. Hypotension 5.6%, 36.9%. Flushing NR 9.8%. Nausea 4.9%, 11.0%. Dizziness 1.4%, 6.8%. Headache 14.6%, 27.6%. Thiocyanate 14.0%. Injection site pain. Although nitroprusside is widely used for the treatment of hypertensive emergencies, compared with alternatives such as nicardipine, it is a dangerous drug. A comparison of safety profiles reported in product prescribing information indicates that a higher percentage of patients receiving nitroprusside 1 experience more adverse events than those receiving nicardipine. Lower incidence of hypotension associated with nicardipine may be explained by its arterioselective action. 2 Lack of effect on venous tone decreases the risk of hypotension caused by drug-induced decreases in preload. 1. Cardine 4, package insert. ESP Pharma Incorporated, 2002. 2. Nitropress, package insert, clevidipine. Ultra-rapid acting, L-type calcium channel blocker. Short half-life, less than 2 minutes. Eliminated via plasma esterases. No renal/hepatic dosage adjustments. Initiate at 1 to 2 mg per hour. Most patients achieve response with 4 to 6 mg/hour. Limited experience up to 32 mg/hour. Maximum 1000 ml daily. Most common. Headache, 6.3%. Nausea, 4.8%. Chest discomfort, 3.2%. Vomiting, 3.2%. Disadvantages. Lipid-based. Contraindicated in patients with allergies to soybeans, soy products, eggs, or egg products. Must be discarded in 4 hours. $145 per 25 mg vial. Experience beyond 72 hours is limited. Successful transition defined as SBP remaining within target range 6 hours after clevidipine discontinuation. Transition to imidazoline receptor agonists, 33%. Angiotensin converting enzyme inhibitors, 29%. Dihydropyridine calcium channel blockers, 24%. Beta blocking agents, 21%. Successfully transitioned in 97.5% of patients. Enalapril prodrug of enalapril. Pharmacodynamics make it difficult to use in hypertensive crisis. Onset 15 minutes, peak 1 hour, duration 6 hours. Dose 1.25 mg over 5 minutes every 4 to 6 hours. Titrate by 1.25 mg increments at 12 to 24 hour intervals to max of 5 mg Q6H. May further compromise renal function. Most utility for CHF. Hydralazine direct relaxation of vascular smooth muscle. Reflex tachycardia, increased stroke volume. Time and degree of hypertensive effects are variable. Onset, 10 to 30 minutes. Duration, 3 to 9 hours. Hepatic acetylation and renal elimination. Use, eclampsia, 10 to 20 mg for bolus, repeat in 30 minutes as needed. Summary. The most appropriate therapeutic option for hypertensive emergencies requires meticulous attention must be paid to. Distinction between urgency and emergency. Precipitating factors. concomitant illnesses, blood pressure goals, pharmacokinetics.